All right, let's dive into a topic that shows up all the time on board exams: myelodysplastic neoplasms, or MDS for short. This can seem really complex, but over the next few minutes, we're going to break it all down into a super simple, high-yield framework you won't forget. So, let's start with this question, because this is the central mystery of MDS. It's this paradox that can be so confusing, right? The bone marrow, our body's factory for making blood cells, is humming along, totally packed with cells. But when you look at the blood itself, the counts are dangerously low. What's going on here? Well, that's exactly the puzzle we're going to solve together. Okay, so how is this puzzle going to show up in the clinic, or maybe more importantly, on a test question? It almost always starts with a classic bread and butter patient presentation. I want you to picture your typical board exam vignette. You've got a patient, they're over 60 years old, and they're just wiped out from anemia, or they keep getting infections because their neutrophils are low. Or maybe they're bruising super easily from low platelets. Or, sometimes there are no symptoms at all. It just pops up on routine blood work. You do an exam, and you might notice they're pale, maybe their spleen is a bit enlarged, all classic clues that the bone marrow is failing. To really get what's happening under the hood, let's use an analogy. Think of the bone marrow as a faulty factory. The lights are on, the machines are running nonstop, but pretty much everything coming off the assembly line is defective and useless. So here's the formal definition, and I really want you to lock in on the buzzwords. First, it's an acquired clonal neoplasm. All that means is a single damaged stem cell goes rogue and starts making tons of identical, faulty copies of itself. This leads to our second buzzword, dysplasia, which just means the cells are abnormally shaped and totally dysfunctional. The result? Ineffective production. The factory is busy, but it's making junk. And this is it. This slide perfectly captures that paradox we started with. On one hand, you look at the peripheral blood, and you've got cytopenias, low red cells, low white cells, low platelets. It's a ghost town. But then you go straight to the source, the bone marrow, and it's hypercellular, it's packed. This mismatch is the absolute most important concept for MDS. If you remember nothing else, remember this phrase: cytopenias with a hypercellular bone marrow. Okay, so you suspect MDS. How do you prove it? Well, now it's time for the board exam buzzword blitz. These are the key findings, the hard evidence that'll help you crack the case. First, you look at the peripheral blood smear. You'll see signs of that shoddy production, like these big oval-shaped red blood cells called macroovulocytes. But the one they love to test, the most high-yield finding, is the Pelger-Hewitt abnormality. This is a neutrophil where the nucleus only has 2 lobes, so it looks like a pair of eyeglasses or a dumbbell. When you see that, your brain should scream MDS. It's a classic clue. Now let's go inside the factory, the bone marrow biopsy. With a special stain, a Prussian blue stain, you might find ringed sideroblasts. These are baby red blood cells where iron has gotten trapped in the mitochondria, forming this little ring around the nucleus. So cool and so specific. Another huge one: dwarf megakaryocytes. These are the cells that make platelets, but they're way too small and all messed up. It's all just more proof of widespread dysplasia. Okay, this number is everything. When you're looking at the marrow, you're counting the blasts, the immature cells. As long as that blast count is less than 20%, your diagnosis is MDS. But the second it hits 20% or more, it's a completely different disease. The diagnosis flips to acute myeloid leukemia, or AML. That cutoff is absolutely critical. So once you've confirmed the diagnosis, you can't just use a one-size-fits-all treatment. The very first step is to figure out a game plan, and that means stratifying the patient's risk. And we do that using something called the International Prognostic Scoring System, or IPSS. It's basically a scorecard that looks at 3 key things: the blast percentage in the marrow, the specific genetics, certain abnormalities like on chromosome 7 are bad news, and finally, how many of the blood counts are low. You add all that up, and it sorts patients into lower or higher risk groups, which tells you exactly how to treat them. So here's the simplified game plan. For low-risk patients, you're mostly playing defense, supportive care like blood transfusions. Now, here's a super high-yield connection. For the specific subtype with an isolated deletion of chromosome 5q, the drug you need to know is lenalidomide. They love that association. For high-risk patients, you got to be more aggressive with drugs like azacitidine. But, and this is a big one, remember that the only potential cure for MDS is an allogeneic stem cell transplant. So, what's the long-term outlook for these patients? Well, as you can probably guess, it's tied directly to that risk score we just talked about. And the difference is pretty stark. It's really night and day. Patients with low-risk disease, especially that del(5q) subtype, have a much better prognosis. Median survival can be longer than 6 years. But for high-risk patients, it's a much tougher road. Median survival can be less than 2 years, and they have a huge 30 to 50% chance that their MDS will transform into acute myeloid leukemia. And this quote really drives home just how serious this is. We talk a lot about the risk of transforming to AML, and that's a huge deal. But what do most of these patients actually die from? It's the direct consequences of the bone marrow failure itself. It's the debilitating infections because they have no neutrophils, or severe bleeding because they have no platelets. So we end right where we started, with that clinical puzzle. But now you have all the pieces, don't you? You see an elderly patient, you see the cytopenias with a hypercellular marrow, and you spot those classic Pelger-Hewitt cells on the smear. With those clues, you can confidently point to the faulty factory of MDS. And that's exactly how you're going to master this on your boards.